Good afternoon, everyone. I request the panelists, Dr. Shayan Chakraborty, Dr. Pradeep Mondol, Dr. Rajiv Bhattacharya, Dr. Reza Kamal, Dr. Partho Sen, Dr. Supratim Bhattacharya, Dr. Arundhati De, and Dr. Sombit Mohanty to join the dais, please. I think Dr. Kaushik Chatterjee won't be joining us today. So today's topic is management of advanced bladder cancer. Now, advanced bladder cancer obviously is a mixed bag of disease. So we'll start with the first case. He's a 72-year-old gentleman with diabetes and hypertension, well controlled, presented with painless hematuria on and off for 1 year. Finally, a non-contrast CT scan was done August 2021, shows irregular wall thickening, right lateral wall of urinary bladder, with adjacent extraserosal fat stranding and prostatomegaly. The TURBT was done in September, shows right side of bladder and trigone filled with mainly solid and necrotic tumor. Left ureteric orifice is obscured and there is tumor coming out of the right ureteric orifice, and it was an incomplete resection. Histopath shows high-grade transitional cell carcinoma, PT2. Following that, a CT scan of abdomen was done, which showed heterogeneous symmetric wall thickening of urinary bladder, right VUJ involved, left VUJ just adjacent to the tumor, perivesical fat stranding, and an enlarged right pelvic side wall node 16 by 10 millimeter involved. The create clearance comes as 52 ml per minute. So what further evaluation? I will go with the surgeons first. Dr. Supratim, yes.
Sir, considering it's a clinically T3 lesion, or at least T3 and N1, I would like to do MRI pelvis. Along with that, I will also do a CCT, thorax and abdomen.
MRI
Alternatively,
pelvis?
PET scan can also be done.
So either PET scan or MRI pelvis plus CT thorax.
Yes, sir. Yes,
Any
sir.
difference of opinion?
I think MRI pelvis, CCT, abdomen, thorax is fine.
CT abdomen is already done, so
yes,
CT
so
thorax.
I don't think PET CT, if there is no clinical suspicion of metastasis, PET CT is not a very good tool for the this type of CA bladder, urinary bladder patients. It can be taken for metastatic workup, but for anatomy, for ureter or bladder anatomy, it is not a very good tool because there is also residual disease here.
Yeah, so point well taken. You can do a PET scan, but it's not essential. You can complete it with a CT scan thorax. So what treatment after this? Suppose CT scan showed clear, CT chest clear, no lung metastasis. On that side, Dr. Sandeep.
So we need to discuss with the patient regarding the bladder preservation or cystectomy. So if the patient wants to go for the bladder preservation, I will go in, because it's a MIBC, so I would like to go for trimodality treatment. Means maximal TURBT followed by concurrent chemoradiation with cisplatin and 5-FU.
Next question to Dr. Shayan. What is the data of trimodality treatment in node positive disease? We know it has in node negative T2, muscle invasive, but what about node positive? Anyone?
See, trimodality is only if there is a single growth. If it is multifocal or patient has got hydronephrosis or like CIN, so in CIS, so in or node positive, we don't go for this trimodality. So if the patient has a only focal disease, we MIBC will go for concurrent chemoradiation.
Dr. Supratim, what's your take on surgery in this patient?
Sir, considering it's N1 disease, I would anyway go with NSCT first approach. And after that, I would see if we can, I think ultimately the patient will end up with a cystoprostatectomy. Because considering the patient's age is more and the kind of T3 disease he is having, I don't see much of option with trimodality in this patient.
Dr. Arundhati? trimodality or NSCT followed by surgery?
No, for this patient, I think trimodality is not a very good option. Maybe neoadjuvant followed by assessment for surgery. And if patient is not willing for surgery or for any medical comorbidities, he is not a candidate for surgery, then concurrent CTRT can be an option. That is plan B.
Okay, so suppose we decide on neoadjuvant chemotherapy, then what chemotherapy? Anybody?
Sir, in this particular case, there will be a few challenges. So the number one is the creat clearance of this patient is 52. So what our experience has been that in a neoadjuvant setting, anything other than cisplatin doesn't work that well. So it doesn't produce the kind of response that we want before surgery.
I would suggest, please, if you can remove your mask and speak, because it will be more clear.
Oh, sorry, sir. So the first challenge is that the patient has creat clearance of 52, which makes it apparently cisplatin ineligible. And in this situation where in NACT we know that cisplatin is almost an essential component of the treatment regimen. So here, first of all, we have to understand what is causing this low creat clearance. And probably there is an ureteric orifice obstruction.
Hydronephrosis is not there.
It's not there. So I think we need to work up whether the thing is whether this creat clearance could be made better by some sort of urological intervention. We need to look into that. And
create clearance of 52, will you consider it totally ineligible, or you can do something?
So what if I don't find anything to increase the creat clearance, in that case I think the divided doses of cisplatin is one option, where we give the cisplatin dose in weekly divided fractions. So that can be done. I would definitely not go for carboplatin based regimen.
Yeah. So that point is well taken. So NSCT should be cisplatin based and not carboplatin. If the patient is cisplatin ineligible, then especially if the creatinine is below 50, then the patient has to be considered ineligible. 50 to 60 is borderline. You can give a modified regimen. So the patient received 4 cycles of gemcitabine with cisplatin with a split dose cisplatin. That is the modification which I was talking about. So you divide the cisplatin on between day 1 and day 8 instead of giving the whole thing on day 1. So you can monitor the patient well, and if the creatinine is rising, you can stop. So after 4 cycles, CT scan thorax abdomen was done, which again shows bladder thickening involving right VUJ, which is same, and the right pelvic side wall node is not seen now. So it was reported as stable disease. If you see here, this is the arterial phase showing that tumor here. In the delayed phase, this right VUJ is involved, left VUJ was free. So again, coming back to both the surgeons and the radiation oncologist, now what to do?
Surgical options are, first option is to do a cystic prostatectomy, and second is a prostate sparing cystectomy. Now considering the patient's age to be 72, and I think other sexual function is not into account in this case, and considering the fact that if we save apical part of prostatic urethra, the chances of second malignancy would be high. So I would say cystoprostatectomy is a better option for this patient, along with standard pelvic lymph node dissection.
Okay. Radiation oncologist?
So it was an M1 disease from the onset. There was a pelvic lymph node which was present. So in case the patient is not medically inoperable or the patient is not willing for surgery, otherwise I think medical cystectomy would be a procedure. If we go for surgery, if we go for radiation, probably a dose of 55/20 we can offer the patient instead of 64/32.
Any other radiation opinion?
The patient is upfront taken from NACT. So for primary treatment, we don't take for the NACT. So if he's already patient taken from the primary NACT, so it should go for the operation until unless in between some comorbidities develop where patient will be inoperable. So for this patient particularly, I would prefer to go for surgery and send to the surgical colleague.
Right. So At the beginning also there were two options. One was NSCT and the other was, even if you go by NCCN, tri-modality is recommended as one. They are like concurrent chemo radiation and then assess for surgery, salvage surgery or something like. Both are options, but definitely no clear-cut better is there. So depending on case-to-case scenario, we can decide. So the patient went for open radical cystoprostatectomy, bilateral pelvic lymph node dissection and ileal conduit on 9th February 2022. Histopath was reported as urothelial carcinoma, sarcomatoid variant, 2.6 centimeter, high grade PT2, margins free, no LVI or PNI, and that right pelvic node was still positive, 1 out of 22 nodes, so solitary node positive. So my question to the molecular pathologist, what is this sarcomatoid variant? Anything special treatment is required or not?
I mean, there are 3 tumors in the bladder. I mean, when we have the sarcomatoid, plasmacytoid, or micropapillary variants.
Please
or the
speak
subtypes.
closer to the microphone.
Yeah.
Yeah.
So those are very aggressive disease, and your platinum-based chemotherapy. I mean, what is deficient in this? What is the percentage of sarcomatoid variant? That is very important. Because, and what type of sarcoma? Because these are the tumors, they are mostly treated with the sarcoma type chemotherapy. That is number one. And secondly, whether CIS is there or not. So now when we are looking at these cases, as compared to the conventional urothelial, they have a very distinct molecular phenotype. And we need to look for like whether it's a luminal A, luminal B type tumor or a basal tumor. I think you have subsequently in the discussions.
Yeah, so that is also a very important point. Nowadays we have all these molecular classification for urothelial carcinoma as well. So this now surgery done, now what treatment? Dr. Rajiv.
So because there was residual disease in the pathological specimen, we need to give some sort of adjuvant therapy, and what is indicated is we can give 1 year of nivolumab therapy. So that can be used here.
Yeah. What about radiation? Adjuvant?
As such, sarcomatoid variant, we all know that everywhere that are radio-resistant, they are considered as radio-resistant. But for this case, for urinary bladder sarcomatoid variant, they have propensity for local invasion and nodal relapse. That's why we can add radiation for specifically sarcomatoid variant as adjuvant treatment. There is definitely role of radiation.
Yeah, so
The data on adjuvant radiotherapy is not so robust. Level 1 data is not there, but so we can discuss in multimodality disciplinary team and we can then proceed. But I don't think there is much evidence of adding adjuvant radiotherapy here.
yeah, especially after post-neoadjuvant chemotherapy.
Yes, exactly.
Until unless there is a margin positive, we can consider radiotherapy, otherwise we
Yeah,
not.
node positive or teeth, you can consider, but
But there is no level 1 evidence actually.
Yeah.
That is
Sir,
So-
sir,
Yes.
there is, I totally agree that there are no evidence. That the problem is that the cost of nivolumab is prohibitive. So most of the patients do not get nivolumab. There, I think radiotherapy.
Yeah,
is
in
the
this,
poor man's.
yeah, in that scenario there is separate. But ideal scenario,
so yeah, this patient received nivolumab for 1 year and completed almost 1 year back, still he is doing well. So going to the second case, now it's a florid metastatic disease, 66-year-old male, good performance status, hypertension, hematuria, and CT scan shows bladder mass, pelvic nodes, bilateral lung mets, biopsy high-grade urothelial carcinoma, create clearance is 65. So again, first Dr. Rajiv.
Sir, can you please show me the previous slide, sir? Yeah. So high-grade urothelial. Oh, okay. So there are metastases already. So we have to give systemic therapy, and in this patients, if right now, sir, the treatment of choice has changed. We are no longer giving only chemotherapy-based systemic agent because of the recent publication of the EV302 data.
No, what you are giving, is that molecule available?
It will be available in I think 2-3 months time. So right now, what I am following is definitely gemcitabine and cisplatin, but
Followed by something.
sir,
Followed by something.
followed by maintenance avelumab. Yeah,
that
so
is available
only
as of
only if it's stable disease. Sir, there is another data which is not that robust, and that is adding nivolumab with gemcitabine cisplatin. But
So what would you prefer, Gemcis followed by avelumab or nivolumab plus Gemcis?
I think Gemcis followed by avelumab is currently
Why?
standard. Sir, because here in this patient, we can stratify them. First of all, the nivolumab data, the CheckMate 901, the data, the benefit is not that robust. There is just about 2 months benefit, and actually the PFS benefit is, I think, few days. And that also achieved statistical significance. So in that situation, I think I will not add nivolumab, rather I would give the avelumab maintenance. In the Javelin trial, there was the benefit was 25 months versus 15 months. And also, we can stratify it. Only those patients who are going to be stable disease or responding will receive avelumab, and those who progress will receive pembrolizumab, which has a separate data. So I will stick with the...
Yeah, so here you can see the overall survival is improved with nivolumab, but median is only 3 months higher. But if you compare that with the maintenance avelumab, then it is almost 7-month gain. But there is one caveat in this. Here you are only taking the stable disease and the responders. So you have filtered out the poor prognosis patient. And if you are giving from upfront nivolumab, you are giving to everybody. And what Rajiv mentioned, this is the game changer study actually, enfortumab vedotin, which is an anti-nectin drug, antibody drug conjugate, which is a cell surface molecule, along with pembrolizumab. So you remove chemotherapy and give only antibody drug conjugate plus immunotherapy, and compare that with chemotherapy, you get a huge PFS benefit, double PFS, and overall survival also double, 31.5 versus 16 months. So definitely cost will be a prohibitive factor, but it will become the drug of choice. Now, suppose you have given, we'll come back to a case quickly. The patient received Gemcis only 4 cycles, partial response, was not decided on maintenance immunotherapy. So patient on observation after 3 months progression. Now we'll come back to Dr. Mohanty. Now in the days of targeted or precision therapy, what test do you recommend at this point?
At this point, do we have the PD-L1 and FGFR status for this patient? The fibroblast-derived growth factor and PD-L1 and HER2. I mean, the data on HER2 is not that robust, but still, I mean, doing a baseline HER2 does help.
So are you doing FGFR alterations in your lab?
FGFR3.
As a standalone test or only as a
We
part
are
of
doing
multi-gene?
one we are doing as a standalone PCR-based and sequencing-based test, and also part of a NGS panel.
Yeah. So that is important thing. FGFR alterations are present in 12 to 35% of advanced urothelial cancer, and this is an important target with this molecule ardafitinib. This is a second line study. They selected a dose of ardafitinib 8 mg once daily. The response rates were around 40%. So in with the conventional chemotherapy and all, you hardly get 10% response rate in urothelial carcinoma. So this can give you 40% in those FGFR mutated patients, and median duration of response was 6 months. And again, this antibody drug conjugate, one we already discussed, enfortumab vedotin, another one is sacituzumab govitecan. It is an anti-TROP2 antibody. We also have our conventional immunotherapy, that is pembrolizumab in second line setting. So, Dr. Rajiv again, so after Gemcis, now progression within 3 months, among the available options, what is your take?
Sir, here I think I will do a NGS, and in NGS I will try to fish for any actionable mutation. One of them definitely being FGFR3, if ardafitinib is available. Otherwise, I think pembrolizumab is also a good option. If the patient progress, we have data that in second line setting, pembrolizumab does produce OS benefit. So in that situation, sir, I think these are the various one-to-one options that I will.
So as of now, pembrolizumab is a good option among all the available. Ardafitinib or enfortumab vedotin are not available through the approved route yet in India. This is a second line study of enfortumab vedotin versus chemotherapy. Survival 12.9 months versus 8.94 months. So the benefit is still there, but not as impressive as in the first line. The first line with pembrolizumab is probably the way to go. And various cohorts are there. Patients who have received cisplatin and immunotherapy, after that antibody drug conjugate, or patient who have received cisplatin ineligible and received only immunotherapy, there also these are good options. Is that for sake of time I will skip it. And in our patient progressed after platinum, no FGFR abnormalities detected. Patient has started pembrolizumab and is tolerating the therapy well. We do not know about the response yet. On horizon, we have studies of dual immunotherapy, also targeting HER2 with novel antibody drug conjugates, and various combination trial of antibody drug conjugate along with immunotherapy are being performed. So any final comments from the panelists? Then we can take one or two questions. Okay, any questions for our panel? Yeah. Microphone.
So more than a question, I feel that radiation oncologist, you all are very at the back foot claiming radiation as a role in urinary bladder. See, I'm speaking offbeat, but the way the medical oncologists, the way they put their foot forward, whether it's a pembro, and after that I cannot even pronounce those words, but still, intent of treatment will be palliative. And you people are hesitating in even, and Dr. Partho being a radiation oncologist, where is the category 1 recommendation you are expecting for? Do we have any randomized controlled trial which has compared trimodality therapy vis-a-vis bladder preservation modality? Next thing, I'm not commenting, I'm just saying. Second thing, even if you look at the SPARE trial, accrual was so slow that they had to stop. And the point which you are mentioning about the adjuvant therapy, even if you see the patients who are having eligible for cisplatin, go ahead. If not, then nivolumab. If not, then if other drugs. But even NCCN also mentions radiation as a LVSI positive, PNI positive, lymph node positive, and it happens to be a category 2B recommendation. Majority of the NCCN guidelines, bearing a few of category 1, others are all category 2B recommendation. That is equally, it's a good enough to put. I think Sandeep put a very good point. I think he told that 55 and 20 hyperfractionate. If medical oncologists can give so many drugs, still being palliative, why can't we give a palliative RT? Overall survival will, if it is an endpoint, is not going to change in any way. Sorry,
Yeah,
Indrani.
sure. As usual, very vocal response from Dr. Tanvir. No, we expect nothing less from you. So yes, I think these are very relevant points, that radiation, both as a primary modality with concurrent chemoradiation after surgery adjuvant, and also in the metastatic setting as palliative, hemostatic and all, those points we did not discuss. Radiation still has got a lot of role to play. So I think that's all from our side. Thank you to all the panelists.
Thank you, panelists, for their discussions. But many more thanks to Tanvir. What should have told by our panelist from the radiation side is told by Tanvir. Definitely, surgery not is the ideal situation, because the acceptability, patient don't accept, and you have the very good machines in hand. Nowadays, radiotherapy is so advanced, you can treat a finest treatment to any centers. Taking not only the private centers, government sectors also have the fine machines. So why radiotherapy should not treat? Adjuvant chemotherapy and neoadjuvant concurrent. Chemotherapy is always there. We downstaging can go for radiation. That is a very good option. Surgery is not today is a salvage. For when you have nothing to do with this, but organ preservation is very important, and patient acceptability. Thank you.
Thank you. Before we conclude the session, may I ask Dr. Sri Krishna Mandal sir to hand over a memento to Dr. Indranil Ghosh. as a token of appreciation. And we'd request the panelists to come forward for a photograph. Thank you very much.